So this has been a Zoster week here. So we've talked about making Zoster. We've talked about Zoster as an etiology for diseases. We were, really so lucky to have Don Gilden with us for several days here, talking about his just groundbreaking work in Zoster. So I'm going to pick up and try to reduce this. So Zoster, the disease, we know it at 30,000 feet. It's varicella in a child. You live to be 85 years old, you have a 50% chance of developing dermatomal zoster. In the mid-90s, everyone started to be immunized for it, so we have a different natural history moving forward. The risk factor for zoster is intertwined with compromised cell-mediated immunity. Humoral immunity actually plays a very low role in this. We know this from our experience with patients with common variable hypogamma. Age and immunosenescence appear to be a key factor. It is interesting to note, and this is a Mayo Clinic epi study, but there are data from numerous countries, both countries that have varicella vaccine and those that don't, that globally there's an increased incidence of zoster. And this remains largely unexplained and can't even be explained on the basis of herd immunity from this. So now let's frame shift this and look a little bit at our world. So here is the world of zoster. In the general population, 3.6 cases per 1,000. Now remember, Stan was showing cases per 100, so we would shift this by a factor of 10. If you look at osteoarthritis, it would appear that the incidence rate is increased, but after age adjustment, this is a good explanation for this. These are just, this is a collage of multiple studies where I've taken kind of a sweet spot. The error bars would be very large, and depending upon severity and co-therapy. Lupus in particular, there are studies that show extraordinary rates, particularly people on cyclophosphamide and high-dose steroids. This is a pinpoint study. This was the WeGet study, the Wegener's etanercept study, where we actually could peg a very high rate of zoster of 43 cases per 1,000 patient years. And I'll come back and look at that number again. So why do we need to prevent this? This is, first of all, this is a very bad disease. I mean, watch those television commercials. They show some of the worst zoster rashes I've ever seen in my life. It's ignominious. But it is bad, and anyone in here that has had it, and we've all had patients, the acute disease can be mild and it can be severe. Yet there are complications that are formidable. Small percentage of patients with complex zoster are hospitalized. Post-herpetic neuralgia, depending upon how we define it, 30, 60, 90, 180 days, is a formidable problem for which we have no cure. There are also focal zoster complications ranging from cranial motor nerve 7 with Ramsay-Hunt to the spectrum of vasculopathy, which I will expand on as I close this talk. This is a great picture from a bygone era showing Ramsay-Hunt with its distribution within the zoster zone. We heard earlier this week that zoster is a vascular disease. This virus lives within muscular vessels for a living. We don't understand what it does there, but it actually reproduces, and it's essential that we understand its role in vascular disease of both inflammatory and non-inflammatory variety. With that in mind, I want to show you something that some of you may not be familiar with. In the past several years, there have been 4 epidemiologic studies of great importance that all have shown a consistent result. That varicella zoster, in and of itself, whether it's on your leg or on your arm or on your face, is associated with an increased rate of stroke over the following year. It's highest in the first few months, and it declines. Whether antiviral therapy promptly reduces that is unclear from these studies. This is one of the more recent studies, all using different designs. Patients with their own controls, matched controls, have shown that the age-adjusted increase risk of this disease is formidable. So take that as something to put into this equation. We're talking about zoster as a painful rash. We're talking about postherpetic neuralgia. Now with the spectrum that zoster is linked to stroke, whatever the mechanism may be, we've heard about, I think this adds intensity to understanding this. And Jeff Curtis and I are evaluating this in the RA cohort right now. The data on zoster and biologics, there is some controversy up to this, and it relates mostly to the comparator arms of prednisone and methotrexate. I think most studies have demonstrated that zoster is increased with biologics, particularly with TNF inhibitors. I'll segue to small molecules now. So now let's go back and look at the data that was shown by Stanley. So what we're really talking about here in the rates of zoster into the tofacitinib trials is 4 per 100. So remember that we get etanercept trial, this was 43. So that was 4.3 here. So you're talking zoster in the range of this very key and pivotal study. And these rates now exceed what we see in HIV patients on combination ART. In the pre-combination therapy, we would see rates of 100, but this is now dramatically fallen. The Vertex drug, which apparently I just found out has been discontinued from its RA trial, has very, very similar rates. It was matter of fact, I was interviewed and I said it was a zoster machine. I hope I didn't derail this program. So let me tell you just a little bit about Zostavax, and I'll share some recent data for you at the end. This is a very important vaccine. It's a single injection. It is frozen, has to be reconstituted. There is expense involved in it, but it's an effective vaccine. The pivotal trial to demonstrate its effectiveness showed that there is a fall in zoster of about 50% and a fall in postherpetic neuralgia of about 2/3. This trial occurred in people over the age of 50. It is recommended for patients over the age of 60. It has its biggest bang for the buck the younger that you are, with waning activity as you get older. So the appropriate time is still to be determined. Bing alluded to the ACIP recommendations, and this is the chart that we're all familiar with. This is where we live. This is the immunocompromised group. These red bars tell us what's contraindicated, and as he noted, this is a live vaccine as the other live vaccines. Everyone who works with vaccine recommendations and works with the CDC chart, which is so simple, know that everything is in the footnotes, and the footnotes are very important. And if it's worth a few minutes of your time to run through these. So the letter of the ACIP recommendations say that this vaccine is recommended for older RA patients, fitting the indication, receiving non-biologic DMARDs, and they give you a scanty list of drugs to benchmark this against. I think if you're getting less than 20 of prednisone, you're getting standard doses of antimetabolites, it is reasonable to give this according to the recommendations. They do not have an exhaustive list of drugs, including alkylators, et cetera. So there are some gray zones for this, particularly in areas where there are no data. They state that it is inadvisable for patients to receive this with biologic therapy. This is based on more on concerns than on data. But it may be reasonable to hold a biologic if that's in the game plan and your shared and informed decision-making with the patient, and then resume biologic therapy this magic 30 days after the immunization has been given. So a little bit of data just to poke the skunk here, as they say. So another very nice piece of work from Jeff Curtis and his group that mined some databases looking at the actual practice of zoster vaccination in patients of Medicare eligibility who have rheumatoid arthritis, and asking the question, was it given to patients with biologics? Is there any signals of safety or efficacy? So this was a retrospective study. This has been now published for 5 years. I give you the high points. They looked at patients with immune-mediated inflammatory diseases, and I'll show you this large cohort. Here you have the unvaccinated cohort of patients with these diseases, 800,000. 10,000 patients got Zostavax. Not very many. And moving forward, that is an issue. One of the things of great interest here is if you look at the Zoster rates within this study, you can see that these rates are quite high for patients on biologics, and the effects of glucocorticoids was formidable. These are rates of 20 to almost 40 cases per thousand. So this is an area of great concern, and however you tease out the effects of methotrexate and steroids, as we give these drugs, we are making people prone to zoster. What was interesting and heartening is that using a sub-analysis of patients who were on biologics who had received a Zostavax, for whatever reason, as you all know, everyone here has a patient like that that has received it generally from an unwitting primary care provider. There were two things that this study concluded. That one, it was safe. The primary safety endpoint was dissemination or new onset zoster within 42 days, the same safety signal used for the pivotal zoster trial, and there was no signal. And secondly, looking at internal signals for new shingles within the year after receiving this, there appeared to be a palpable decrease with this hazard ratio showing protection. So, you know, here, this is not a prospective study. This is mining a database, but it was very provocative and said, you know, well, what, you know, maybe we should be looking at this in some clinical way. So I love this study. So Steve Lindsey, known to many people here, he's just a smart guy. He said, I read this paper. He said, it sounds like it's a good thing to do, and maybe we should just go ahead and try it out. And far more thoughtful than that, but he has looked at his patients in his practice, several hundred patients on biologics. He took patients over the age of 50 where it's recommended, and looked for contraindications for this aside from the disease and its drugs. And then he said, okay, I'm going to take, everybody's on a biologic. I'm just going to hold that biologic at the next interval when they should get it. And then I'll hold methotrexate for the week of the vaccine. And then I'm going to give them Zostavax. And then I'll restart everything 2 weeks later. And I'm going to follow these people meticulously, and I will look for the same type of safety signals that went into this. And without even showing you the data, no patient developed shingles within 6 weeks, and everybody's doing quite fine. So I think it was a very pragmatic approach to this that is further encouraging. Now, the real proof of this will be in the Verve trial. I'm sure Bing will be part of this. This is PI'd by Jeff Curtis and Kevin Winthrop, who are in the early first quarter phase of this trial, where patients on biologic therapy will actually be given Zostavax and then followed for efficacy and safety, and then an intense subcohort for pathophysiologic markers, et cetera. So this will take some significant time to get through this, but the initial question should be answered by this trial. It's also been used in the AIDS clinical trials group for over 5 years. In patients down to 200 CD4 cells have been getting Zostavax with a safety and efficacy trial, which is not in manuscript form, but there have been 3 abstracts on this showing no significant safety. I can answer questions on that later. This is a very new paper that you may not have seen. So the question is, what happens to the enduring effect of Zostavax? We've known when you follow antibody levels, which are a very poor correlate of immunity, that they decline by 7 years. The rates of protection, particularly in older age groups, start to wane. But the ACIP actually weighed in on this in February and said no reimmunization at 7 years. This new study extends the follow-up to Zoster to 11 years. And the point that I make here to highlight is that at 8 years, the protection rate now is lost statistical significance. So this is going to have to be dealt with, and the cost effectiveness of this vaccine is going to have to be reconsidered, and policies and positions to address this. Now, there's a lot of devil in the details, you know, age group specificity, when you're going to get this, but this is a paper, an important paper that deserves to be read, and there's a nice editorial on this. Now, even hot off the press, and in this current New England Journal of Medicine this week, which I had to run back and take a snapshot of to put up here, is an extraordinary article of the GSK vaccine data. So this is a Zoster vaccine, but it is it is not a live vaccine. It's a glycoprotein subunit of Zoster given in an adjuvanted format. The adjuvant is a lipid adjuvant that has been used in other trials, including hepatitis B. So we know a little bit about the safety of it. This was given to patients from 50 through older age groups, and here's the bottom line. So this is at 3 years. Now, this is extraordinary degrees of protection, from 96 to 97.9%, with a single vaccine of a killed agent. I mean, dead, it's a protein. So this makes us think of, you know, what will be the next steps. Now, what is the safety signal here, and what are our concerns? Well, this is a potent adjuvant, and there were a significant number of grade 3 reactions. Most of it were local regional injection site reactions, but there's a lot of, you know, some fever, things like this. But in our business, you know, adjuvants, autoimmunity is always a need for concern. Bing could comment on ex-US influenza studies that have used adjuvanted preparations that we generally do not use, and those have been relatively safe. But this is a different adjuvant, different ball game, and this will have to be studied. Now, this has already gone in advanced clinical trials for hematopoietic stem cell patients, and this could be very much of a game changer moving forward. So my summary is, yes, we are in the VZV business. And I think that we all should have a great deal of comfort in understanding this disease, treating this disease, preventing this disease, and developing strategies, as Bing said, you know, early on to deal with this. I would keep my eye on this literature, and I think most of us in this room that were here earlier this week are certainly going to keep our eye on the expanded world of vascular diseases. So I'll close, and we can move into the panel. So thank you very much.